Hello, everyone. Good afternoon, good evening, and good morning to all of you who have joined in today from across the globe. So it's my absolute pleasure to welcome you all to today's webinar on standard of care of chelation therapy in thalassemia major. This webinar series, which is named Advanced Webinar Series in Diagnosis and Management of Thalassemia, is being jointly organized by the Thalassemia International Federation, Thalassemics India, Postgraduate Institute of Child Health, and ECO India. These sessions bring in expertise of both international and national speakers to address issues pertaining to thalassemia care in India. So this month, the topic we are discussing is standard of care in chelation therapy. And we are truly honored to have such a diverse and distinguished faculty and audience who is joining in from across the globe today. Thalassemia major, as you know, is a complex lifelong condition that demands a lot of multidisciplinary care. And among one of its core challenges is iron overload, which is a consequence of regular blood transfusion as well as increased iron absorption from the gut. So chelation therapy remains not just a treatment, but it is the lifeline for children and for adults who continue on the standard arm of treatment, as in that's lifelong chelation and transfusion therapy. So to introduce the topic today, I welcome Dr. Andrula Eleftherio, Executive Director of Thalassemia International Federation. Over to you, ma'am. I think she's joining in she's on way, I think. So they said they could have some signal issues. So I would request Mrs. Tuli to discuss the context of today's topic to Indian scenario. Mrs. Tuli is the secretary and the founding person of our Thalassemics India, a national non-governmental organization working for the care of thalassemics in our country. Over to you, ma'am.
Okay, so before I start what I have to say, just Dr. Nrula informed me that she's calling me downstairs to the lobby. But since you had already started, so I think after I finish mine, I'll go down to the lobby and join with her. So on behalf of Thalassemics India, I once again welcome all of you, all the delegates who have joined us today, and the chairperson, of course, Dr. Nrula Eleftherio, and both the speakers, Dr. John Porter and Dr. Jagdish Chandra, both have been my mentors. I have learned a lot about thalassemia from both of them as an international expert as well as a national expert, and my colleague, Dr. Neeta Radhakrishnan, at the ECO webinar series. As we all know that today is the 5th session, and under the ECO webinars series on advances in thalassemia care. And today's topic is standard of care in chelation therapy. You will all agree that we have heard about this topic, and this topic has been discussed on various platforms for many years. We fully understand the importance of chelation therapy in the life of thalassemia patients. And I am quite confident to mention it here that the patients who are living in the big cities and in the developed world and even in the developing countries, some of the developing countries where the treatment is supported by the government, they fully understand the importance that what are the iron levels that they have to maintain, what are the techniques available in their countries and in their cities to measure the iron overload in their bodies. In spite of all that, and even you will agree with me that I have seen it personally. I have visited the countries where the chelation medicines are provided free of cost by the government, but the patients are not fully looked after that. And maybe the ignorance is there. Maybe they are not listening to their doctors. So compliance has been issue for many years. What I want to say here is, I'm sure both the speakers will try to touch upon these issues, that what are the reasons that why our patients are still struggling uh, by not having the recommended values of iron in their body, and also the two measurements, because liver biopsy is outdated now. It's not done that quite regularly, and it is not advisable also. If the measurements, if we have to do it by serum ferritin or by T2 MRI, Do our countries have all that equipments available? Are they affordable? Are they we can rely upon such equipments, or still, we are struggling to have the T2 MRI established in most of the even the developed countries, and whether the results are so accurate when we see it clinically with the measure it with the patient's growth and all that. So I would request both the speakers, looking at the conditions in our country, and especially my request to Dr. John Porter to come up with some of the input and the comments that how effectively together, we talk about bringing the best practices in our country, but when it comes to the reality, when it comes to the practical problems, maybe you have better suggestions to give to us, because this one after this will be available, this webinar will be available, recorded option will be available on YouTube for patients and parents to hear. So once again, I request and I thank both the speakers for giving their time. And I would request if you can touch upon such topics so that it could lead to a better care in our country and in other countries where this is really required. Thank you very much. And over to Dr. Neeta, please.
Thank you, ma'am, for that introduction.
And allow me to go down. Allow me to go down and join with Dr. Ndula, please. Thank you so much.
Sure.
Thank you.
So it's our absolute pleasure to invite Professor John Porter for the first talk. So Professor Porter is Professor of Hematology and Consultant Hematologist at the University College London Hospitals in the UK. And he is the head of the Joint Red Cell Unit for UCLH and Whittington Hospitals. His research focus has been treatment of thalassemia and sickle cell disorders, with particular reference to iron overload, which we are discussing today, and the molecular basis of iron homeostasis. He's been the principal UK investigator in numerous multi-center clinical trials, especially the ongoing trials for luspatercept as well as gene therapy for thalassemia. He's published more than 350 peer-reviewed articles with over 10,000 citations and has served as the scientific advisor to the British Society of Hematology. It is our absolute pleasure again, sir, to invite you today. Over to you. Thank you.
Thank you very much for that kind introduction. Let's get the first slide up before I start talking. Shall I do that? You need me to do that?
Yes.
Okay. Yeah. And so it's on my screen. Do I do press share?
So on the bottom of this Zoom screen, you'll find a share option.
Yeah.
Yes. Then you can select your PPT.
Okay. So thank you very much for the kind introduction. I have to say, I have recently retired, so I no longer have those official positions, but I'm still working at UCLH and UCL, continuing research and seeing patients. But I've retired from those official positions. So I am going to try and just get this up. Moment. Here we are. Yeah. So I've thought about how to do this. We have obviously guidelines from the Thalassemia International Federation, which aims to help people and to give examples of best practice. I recognize that in all centres, including our own, it is not always possible to maintain the highest standards. Nevertheless, that should not be a reason for aiming lower. Otherwise, we will get even lower outcome. I'm going to try and focus on general principles of chelation rather than individual guidelines in different countries. As you know, circumstances differ in different countries, availability of chelation, The availability of clinics, the availability of specialists with time to spend with patients to help them adhere, that is hugely variable across the globe and also within countries. So even in the UK, we have areas where we're much better resourced to help people who are failing to comply than others. So the talk is about chelation, and I just wanted to make the first slide the point that iron chelation isn't just used for thalassemia major, and our experience in other conditions does inform some of our usage of the chelating drugs. So thalassemia major is undoubtedly the best described chelation um, uh, paradigm, but other conditions such as sickle cell disease, non-transfusion dependent thalassemia, myelodysplasia. A lot of people with myelodysplasia, both in chronic state or coming up to a bone marrow transplant, need chelation, and that needs to be given. And there are special considerations in that group because patients tend to be older, they have less renal reserve, for example. So we can use that experience to help us uh, look at the relationship between dosing and toxicity. And the other point is that chelation doesn't just affect total body iron, it affects iron distribution. So there are conditions, neurotoxic conditions, where iron distribution is the problem, such as Parkinson's disease, superficial siderosis, and aceruloplasminemia. In all those conditions, iron is distributed in an unusual way in the brain, even though the total body iron may not be particularly high. So, what are we trying to achieve with chelation therapy in thalassemia? We're trying to balance the input from transfusion with the output from chelation. And we need to monitor that in a way which is achievable and useful. We need to achieve harmless levels of body iron. Now, I think this is an opportunity just to discuss what we mean by that. The general view, well, there's two ways of doing it. One is to look at the ferritin, and another is to look at liver iron. Of course, we can talk about cardiac iron later. So, using ferritin to achieve harmless levels of body iron is problematic because ferritin can be raised for reasons which don't relate to iron overload. In Europe now and in the United States, fatty liver, infiltration of the liver by fat due to being overweight, diabetic perhaps, leads to a rising in the serum ferritin, which is independent of the degree of iron overload. And if, therefore, we use ferritin alone to decide when dose reduction is necessary, we may get caught out and we may actually overtreat patients. We want to, with prevention, to detoxify iron pools, and this is really important to considering what regime to give. If chelation is only given during the daytime hours, some chelators are going to be more effective at detoxifying the iron than others. D-ferrocyrox, or XJade as it was originally known, has a very long half-life, and so if you give it once a day or possibly twice a day, you're going to get good coverage in terms of detoxifying the iron. Diferoprone has a shorter half-life, and if you go from 3 times a day, which has been the traditional way of doing it, to twice a day, although you may get similar levels of iron balance, you may not get similar levels of detoxification of iron. This is just in principle. So prevention is really important. If we can avoid iron building up, we can avoid a lot of the toxicities from the labile iron. Unfortunately, as Shavatori just said, too many people are unwilling or unable to take chelation in a frequency that is really optimal for controlling the iron. So many patients end up with high levels of body iron. High levels of body iron in the context of thalassemia major, we mean liver iron concentrations probably above 7 or in extreme cases 15, above 15 milligrams per gram dry weight. That is going to be problematic. And then patients with high levels of heart iron. Now, of course, if you're not monitoring to measure heart iron, you don't know. But if we are able to identify increased levels of heart iron, then we need to intensify our chelation. And then finally, just touch on, because there isn't time to go in much detail, what do we do if the patient's heart starts failing? So the tools we've got are desferal, deferriprone, and deferricerox. They go under different names in different countries. And now that deferricerox has come off a patent, we have at least 10 different preparations in our country, and we need to make a judgment as to which is the most appropriate for our patients. And I know there are many formulations of deferriprone worldwide. Interesting that the desferal preparations available have dropped. It's much more difficult to make and more expensive. So with deferriprone, it's traditionally been given 3 times a day, but there are some studies which have allowed approval for twice daily dosing by the FDA. So desferal has a very short half-life. It's cleared very quickly from the system, at least in the iron-free form. Deferriprone has, again, a shortish half-life, not as short as desferal, and deferricerox or Exjade has a longer half-life, and therefore giving it once a day makes better sense. Although, as I say, some people give it twice a day. The iron comes out in different ways with different treatments. The desferal, the iron comes out in the feces and the urine. Deferriprone almost exclusively in the urine, and with Exjade mainly in the feces. Now, in terms of the adverse effects of the chelators, some of these are dose dependent and some are dose independent. Desferal causes local reactions at the site of injection. It can cause eye problems and auditory problems, particularly at higher doses and at low levels of iron. So this needs to be monitored for. Growth retardation in children was an early problem when the drug was introduced, and anyone on desferal needs to have their height monitored to see if there's any fall away from the growth curve prior to starting the desferal. Allergies have been described with desferal. Deferriprone, gastrointestinal disturbances, changes in the liver enzymes, agranulocytosis, so the absence of white cells or severe reduction in white cells in about 1 to 2% of patients, neutropenia without the agranulocytosis, and arthralgia, swelling of the joints, can be a problem. It seems to be more of a problem in the Indian subcontinent than we see in the UK. We don't see a lot of that. In terms of Exjade, minor to intermediate gastrointestinal disturbances are common. A non-progressive increase in creatinine is seen in about a third of patients, but in the elderly, often this increase in creatinine is dose limiting. So it is a significant issue when choosing monotherapy with deferricerox, and particularly in older patients. Liver enzymes can be elevated, but it's not generally a problem. There's some individuals. And then you'll see at the bottom, chelation efficiency. Now, this is a concept I introduced. I think it's actually quite useful. So if you look at Desfrel, it's not particularly efficient. Only about 13% of the drug you give ends up being excreted in the iron-bound form. With Diveripone, it's even less at 7%, and then with XJ's a little more. But you can see that chelation is a fairly inefficient process. And I don't have time to go into that in much detail today, but it's by the nature of the chelatable iron pools in the body, most of which are inaccessible most of the time. So I've just said that. Only a finite proportion of body iron is available for chelation at any moment. The chelator efficiency is therefore low. It may take years to remove iron once it's accumulated. So if somebody has been a poor adherer or poor complier for several years, it's going to take, even if they start taking their treatment regularly, a long time to get it back into the normal range. And so prevention is much better than cure. And if you try too hard, too fast, you risk toxicity of the chelator or more toxicity. The pharmacokinetics of the chelator and the design of the chelator obviously has a bearing on the relationship between toxicity and efficacy. I'm going to mention, but not in huge detail, how we can use combined treatments to get around some of these problems. So what we've got with chelation in general is a balance between too much chelator and too much iron. Too much iron causes a free radical generation, organ damage, growth failure, organ failure, cardiac death, or can do. Too much chelator can cause excess free chelator, which can inhibit metalloenzymes, cause neurotoxicity, growth failure, renal toxicity, particularly in the case of XJ, and bone marrow toxicity, particularly in the case of Diveripone. Does chelation therapy work, and what's the evidence? Well, it does, and there's many papers. I've just put one traditional one here from Borgna Pinati in Italy, showing birth cohorts between the 1960s and the 1980s. You can see that survival up to the age of 30 has dramatically improved. That's mainly with Desfrel. How can we do better? How can we do even better? Because I think most doctors who look after these kinds of patients see patients who fail. And generally, this is because the patients are unwilling or unable to take chelation often enough and don't come to the clinics often enough. So adherence optimization is probably the most important thing. Now, if you've got a very dedicated hematologist and a manageable number of patients, that can be achieved by that single person or by a very dedicated nurse specialist. But once you've got clinics of 200 or so, it's very difficult to give the individual that level of care and attention that they may need. And we have used for many years clinical psychologists to help us with this. But the answer to this is very country specific, and not just country specific, also center specific. So depending on where you are, the bringing of experts to manage the patients is going to be different. The dosing is absolutely critical. So very often I go to meetings or I see patients and they say, "Oh, I'm on this, I'm on Desfrel, I'm on Diveripone, I'm on XJ," as a kind of binary thing. You know, you're on it or you're off it. That is so much not the case. You need to adjust your dose and your frequency relative to the degrees of iron overload and its complication. So regimen optimization is really key. Now, one approach is to increase the efficiency of chelation. I've already said chelation is actually quite efficient if you look at the amount of the drug that you give that gets excreted with iron on it. And there's one that we know, which is vitamin C. So if you give vitamin C with desferrioxamine, iron excretion is significantly increased. The evidence that the other chelators respond to this approach is not good, mainly because the studies are not good. So there was one small study with diferoprone which didn't show a dramatic effect, but I'm not sure it was done carefully enough to come to that conclusion. And no one's done it with Xjade. We did a small study where we found quite a lot of the patients on Xjade become vitamin C deficient, and that's because the vitamin C gets oxidized in severe iron overload. Hello, can you hear me?
Yes, we can hear. Please continue.
Okay, there's someone speaking.
Manisha, could you mute others, please?
Everyone is muted.
Okay. And then we want to, we're seeing this more and more now, is that as chelation is, we have a whole cohort of patients now who are very well chelated. They have been, let's say, on Xjade for a number of years. Their ferritin is close to or lower than 1,000. But we want to be able to adjust the treatment that reflects that. And that isn't straightforward. And I think we're still learning how to do that. So very careful monitoring of the ferritin and the liver iron. I'm making a case for measuring liver iron. I know it's not always practical in India, but it is desirable. And this is because of fatty liver and other things that can put the ferritin up independently of the iron overload. And if you don't have a measure of liver iron, you can get this badly wrong. I'll leave that. So the traditional treatment is desferal monotherapy. Very good cohort data on this, but obviously it's difficult for patients to take it, and many patients don't like doing it or don't do it. Worth saying that once you get cardiac problems, continuous intravenous desferal or continuous subcutaneous desferal is probably the treatment of choice for those with heart failure. Diferoprone monotherapy, 3 times a day is traditional, but twice a day, as I say, now been licensed in the United States. Deferoxyrex monotherapy, I'm not going to expand on that at this moment. And then combined therapies. When should we use them, and how can they best be used? These combinations can be given at the same time, so that if you give, for example, Xjade at the same time as diferoprone, you can get shuttling. I don't have time to show these data, but you can get shuttling of iron from diferoprone onto Xjade with increased iron mobilization. Or you can give them sequentially. So you can give, let's say, Xjade in the daytime and diferoprone, or no, so let's say diferoprone during the daytime and desferal at night. Now, these are not overlapping so much, so the increased chelation you get is just simply due to increased exposure rather than drug interaction. Okay. So simultaneous chelation, we can potentially decrease non-transferring bound iron. We could do that with sequential treatment as well. And we need to know which combinations are most effective. But I think it's fair to say that most clinicians, to some extent, adopt an empirical approach. If somebody's not doing very well with monotherapy, one sits down with them and almost bargains with them. Well, what can you take? What do you think you could take? Could you take this particular chelator 3 times a day, 3 times a week, once a week, twice a week? It's a matter of getting as much chelator in as possible without giving too much. And already said, we know, I've mentioned what the potentials, pitfalls of excessive chelation, enzyme inhibition of cell proliferation and cell death, and the specific toxicities I mentioned in the first slide. There are practical issues with chelation and trying to decide how much chelator we need to achieve iron balance. I just make the general point. Some people actually get a very low transfusion burden. So let's say you've started life as NTDT, non-transfusion dependent thalassemia, but let's say you're coping less well and you need to start with some form of transfusion. Often their transfusion loading rate is still relatively small, and therefore the amount of chelation you need is going to be less, and this should be adjusted accordingly. There are specific issues in and around rescue therapy when you've got myocardial iron present and poor heart function. I've got a slide on that later. You don't need to look at these numbers in any detail, but we can see that most thalassemia major patients and TDT patients have a transfusional rate between 0.3 and 0.5 milligrams per kilogram per day. Some are more than that, about 20% are less than that. And therefore, you can adjust your chelation doses. I'm not going to read out the numbers on this, but basically, you can adjust your doses, in this case with Desferal, depending on the rate of transfusion so you can get balance. Now, you don't have to adhere to this too strictly because often your iron balance is determined more by how often the patient remembers to take the treatment than your carefully constructed values. Hello.
Please proceed. Please proceed.
Okay. There's someone coming. Okay. So this looks at the relationship between iron excretion and dose with Desferal and deferoxyrox, and you can see there's a very nice relationship between the dosing given and the iron excretion. So we can use that in part of the planning of treatment. With Desferal, we knew that there were big toxicities if you started too early, and so transfusion chelation with Desferal is usually not given until 20 transfusions have been given. Tends to wait till the ferritin is over 1,000, and then the dose in children is minimized until growth has stopped. The traditional ferritin to keep below was 2,500, although we would aim for lower if possible. And we're trying to get the liver iron less than 7 milligrams per gram dry weight if that's available for monitoring. We would intensify treatment, and then this is a general point with chelation in general. If the ferritins are consistently above 2,000, 2,500, or if the liver iron is greater than 15, we know that when the liver iron is greater than 15, the risk of heart iron increases. We also know that some patients get dysrhythmias. The older thalassemia patients get this anyway. Of course, if the iron in the heart is too high, we get failing heart function. We need to decrease the dose when the ferritin is less than 1,000 or when the ratio of the dosing to the ferritin is above a certain value. There are benefits of liver iron control. We know that there's an absence of pathology in the liver when the liver iron is consistently less than 7 based on experience with other diseases. We know that liver pathology is much more likely when the liver iron is above 15 to 17 milligrams per gram dry weight. And we can actually now, the FibroScan, which you may be using, is a fairly inexpensive, albeit unvalidated to some extent, a technique which can give you an indication both of the liver fat and the fibrosis in the liver. And we're using this more and more. And of course, we would recommend monitoring the heart function as well as the heart iron using the T2 star technique if you've got it, and if you can validate it properly to identify high-risk patients who need intensification of treatment. So in principle, we're aiming for control of liver iron to prevent problems in a safe way. I've already covered this point, I think. The toxicity with other chelation regimes is less obviously related to dosing. there is a clear relationship to kidney toxicity with Exjade. With diferoprone, it's not obviously related to dosing because the studies haven't actually been done in that way. And I'm going to speed up a little bit. So when the ferritin starts falling, we need to reduce the dosing so we get what so-called soft landing, so we don't overchelate. If we may wish to rescue patients if they've got very high levels of body iron. So if the liver iron's above 15, say, we need to consider adherence or a new regime or an additional regime. Then if we do have high levels of body iron, we need to recognize it. We need to sit down with the patient and discuss how we can improve compliance, or we may need a switch regime. So compliance, dose frequency and timing, poor control of liver iron, or ferritin with diferoprone. We may need to increase the dose, or we may need to think about combined treatments. And then in terms of rescue, when would we need to rescue? By rescue, we mean people who are really getting into problem. They may be problems with liver function or liver fibrosis, or it may be cardiac. The most important ones, of course, are the cardiac because they're the most imminent. If the T2 star of the heart is less than 10 milliseconds, there's a high risk of developing heart failure. And we need to work on adherence issues. I've already covered our approach to that. If there's actual heart dysfunction, if the heart is not working properly, if the ejection fraction is not good, this is a medical emergency, and patients need to have continuous chelation therapy of some kind. And we can talk more about that in the discussion. I think I've allotted my time, and I'm going to stop there. Thank you.
Thank you, sir. Thank you for that lucid discussion on chelation and how it has evolved. Now, if you could stop sharing slides. Now we'll have the next speaker and we'll take the questions together. I would request both the speakers to discuss the questions which have come up in the chat box. So for the next talk, it's our privilege to invite Professor Jagdish Chandra. Sir is Professor of Pediatrics and he's currently serving as the Professor and Head of Department of Pediatrics at ESI Medical College, Faridabad. He has spent over 3 decades as faculty and later Head of Department of Pediatrics and the Director of the prestigious Lady Hardinge Medical College in New Delhi. He established the hematology services at the center, which is one of the largest public sector hospitals treating thalassemia in our country. During his tenure, he also established the transition of care for thalassemia patients to adulthood. And again, the Department of Medicine is probably the only public health sector hospital where adults with thalassemia are managed by an adult care team in our country. And there are several other firsts, including establishing treatment for aplastic anemia, children with cancer, etc. He was also instrumental in establishing an antiretroviral therapy center at this hospital, which was later upgraded as the Center of Excellence for HIV care. His research interests are thalassemia, nutritional anemia, Hodgkin's lymphoma, etc. He's currently serving as the chair of the hemoglobinopathy subcommittee of the Indian Pediatric Hematology Oncology Group. And under his leadership, the first IAP PHO guidelines on thalassemia was developed and launched in 2023. He's also working on the role of thalidomide therapy in patients with transfusion-dependent thalassemia. He's a member of the expert group. He has served as a member of the expert group for development of guidelines for hemoglobinopathies and for the disability certification for hemophilia, thalassemia, and sickle cell disease. It's our honor to have you join us, sir. Over to you, sir.
Thank you, Dr. Neeta, for that very kind introduction. In fact, since the time I was told that the session would be taken up by Dr. Porter, I was little in the awe that we have, in a way, we have sort of grown up in our academic careers reading the work of, I think Dr. Potter's screen sharing is not yet over. Miss Manisha, could you request Dr. Potter to stop sharing?
Yes. Uh, yes, they have already stopped sharing.
All
So you
right.
can
Okay.
see.
Yeah. So, let me share my slides.
Yes, sir. It's visible.
Okay.
Yes, sir. Yes.
Yeah. So, we have, in fact, academically grown up reading up the work of Dr. Porter and Dr. Piga and Bogna Pegnati, which Dr. Porter also mentioned her work. And in his talk, he has elaborated in a very, very short time. He has elaborated the 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 basics as well as the practical aspects of the preventive as well as rescue iron chelation therapy, and briefly touched upon the pharmacokinetics, etc., of the drugs. Why we need to give a drug thrice a day and once a day, or not in a oral form, and talked about the combinations as well. So I basically would be doing the the thalassemia management as far as the chelation therapy in Indian patients is concerned. So in next 20-25 minutes, I think we'll see that, and this already has been uh, uh, dealt with. That uh, what happens in the patients with thalassemia is that iron overload occurs due to ineffective erythropoiesis, hemolysis, and the transfusions. Iron overload results, and this leads to organ dysfunction in thalassemia, particularly the heart, liver, and endocrines. And so the disease, which is a hemolytic anemia primarily, results in a multi-systemic disease with involvement of the endocrines and liver and heart. So what chelation does, it has been explained that it excretes the extra iron from the body. Organ iron deposition gets minimized. So it prevents and reverses the organ dysfunction. The reversal is from some organs, it is extremely good. In some organs, it is not all that good. The endocrine dysfunctions are hard to revert back. And so with that organ dysfunction reversal, there is improved quality of life of the thalassemics, and obviously it prolongs the life of these patients as well. So if we see the introduction of the chelators in 1995, basically the deferiprone was introduced in Indian market. It was approved by the Controller General of India. Before that, only despiroxamine was available, and uh, maybe at least in my center, just about one out of some 150 patient was receiving despiroxamine. So virtually it was the patients who were receiving despiroxamine, that was maybe close to 1 or 2%, not more than that. But in 1995, deferiprone was introduced, and that occurred because of the two studies which were done by Dr. M.B. Agrawal on the efficacy of the deferiprone in Indian patients. The first study appeared in 1991, and in this initially they gave a 25 milligram per kg per day of deferiprone, which was increased to 100 milligram after 1 week and continued for 3 months. And you can see that they initially focused on the demonstration of increased urinary iron excretion, and you can see that some 5 to 6 fold iron excretion in the urine increased by giving 100 milligram per kg per day dose of deferiprone. And the patients in 3 months' time also a mean drop of some 900 nanogram per ml of the quercetin was shown. The next study appeared just a year later, and this was a little long duration. This was a mean duration of 14 months or so. and again showing that on 100 milligram per kg per day, some sevenfold increase in the urinary excretion, and mean drop in serum ferritin of 1465, and it decreased from 3600 uh, uh, 41 nanogram to the 9 months of therapy. So there was no evidence of neutropenia, thrombocytopenia, ear or eye toxicity, but arthralgia was observed in nearly 40% of the patient, but that was reversible on dose reduction or stoppage. So with these two studies and persuasion by the NGOs working like Thalassemics India and National Thalassemia Welfare Society working with the Government of India, the marketing of diferiprone under surveillance was approved by the Drug Control of India, and this changed the management of thalassemics in India. So I would just discuss a couple of studies which showed long-term benefit from diferiprone use. This is a study in which the authors have reported uh, uh, mean duration of 6 years use of diferiprone in 110 patients with a mean age of 17 years, initial dose being 70 milligram per kg per day, initial ferritin close to 3000 mean, and finally it going down in about uh, the mm, uh, going down to 1665 nanogram per ml. So in they have a follow-up up to 15 years, and so the efficacy of diferiprone was shown. And these patients, in some of them, they observed arthropathy, neutropenia, agranulocytosis also. But by and large, the therapy was well tolerated. There was some transient mild leukopenia and thrombocytopenia and some GI problems as well, but they were reversed on decreasing the dose or stopping the therapy. But the other studies did not show that much improvement. Like in this study, which was done from SGPGI Lucknow on 130 patients with thalassemia major, they had divided their patients into three groups. The group one, which had ferritin of less than 2000, group two, 2000 to 4000 ferritin, and group three, where the ferritin was more than 4000 nanogram per ml. And diferiprone was given in nearly 59% patients received for 6 months to 72 months, that is 6 years, and 44% continued diferiprone for at least 3 years. But what they observed was that only 19% patients showed decline in ferritin, nearly 50% remained stable. In some patients, there was rise in ferritin, and uh, uh, 18% passed to a more severe class of ferritin. So this efficacy of this drug was not uniformly documented in Indian patients. And they also observed that in 23% patients discontinued treatment due to joint pain, neutropenia, thrombocytopenia, GI intolerance, and very poor compliance because of the drug we administered 3 times a day. So, and this group also reported something which was not reported before that. This is the resorption of the ulnar head, and this was later documented in another two studies as well, one from our center and from Mumbai, and this led to the ulnar deviation of the hands. And some of these patients at my center, they even required uh, surgery for the correction of this ulnar deviation. So this adverse event effect was also observed, but overall, the use of diferiprone got minimized because of the the arrival of deferasirox in the market. And deferasirox therapy again, this study just I think 1 year of follow-up the patients. So this after 1 year of follow-up, the 40 children, um, there was a fall of hemoglobin, the ferritin from 6,300 to something like 5,400. Therapy was well tolerated. Just nausea, vomiting were there in some 15 to 25% patients, but overall the therapy was well tolerated. There were skin rashes and some grayish brown pigmentation of the skin in some patients was observed. And as it is reported from the Western literature, there was non-progressive rise in serum creatinine in 40% patients, but none of the patient had creatinine in the abnormal range, and the cytopenias were not observed. So another study which showed efficacy of deferasirox at the dose of 33 milligram per kg. And they showed a fall of ferritin every 3 months measured up to 18 months. And this fall was documented from 3,500 to something like 23, 2,400 at the follow-up of 18 months. They also looked at the cardiac T2 star MRI, and in those patients where the value were poor, the severe myocardial iron cases, there was a change from the pre-treatment value of 8.3 to post-treatment value was 10.4. And similarly in other also, but they noticed that percent change in cardiac iron was greater in high risk and intermediate risk patients than low risk patient. Now, this study also highlights that the use of deferasirox was important, and by this time, the at least the larger centers in the country, they had started using the MRI for monitoring of these patients. There are other studies as well with the long-term use of deferasirox, but I would present just one more study that is on 85 patients with a mean age of 15 years. 75 patients were receiving monotherapy of deferasirox, and what this study showed, in fact, the left side graph shows their earlier study where over a period of 3 years, they had shown fall of ferritin from 4,500 to something like 3,000. And then in this study, over a period of 10 years, they showed the fall from 3,000 to 1,065. So a, a very significant fall, and now the ferritin in most cases is in the accepted range, that is under 1000 nanogram per ml. So they also looked at the MRI status of the liver and heart, and just about 7% cases had moderate to severe iron overload in the liver, and 2.3% patients in the heart. And evidence of endocrinopathy was seen in 22%. So no severe chelation related toxicity was noted in any of these patients over the period of 12 to 13 years. So MRI based monitoring, as I said, was being done in several centers. This is the data from PGI Chandigarh. They observed 50 thalassemia patients who were transfusion dependent on different chelation regimens, and they found that myocardial iron content was normal in 68%, but the liver iron content was normal in just about 14%, and they correlated several parameters. Best correlation was that if the ferritin was lower, it was more chances that the liver and the cardiac iron would be, but the drug regimen did not have significant difference in the mean myocardial iron content values in these patients. So with this, I move on to the combined oral chelation, because as we see that in patients not who are not being managed in the large centers, the serum ferritin continued to be very high, and it was expected that with the use of one drug alone, it would take a very long time to bring down their ferritins. So a combination of oral chelations was started. Again, one study from PGI Chandigarh done on 36 patients. The serum ferritin in this group was 6,700 to start with, and more than 5,000 in 53%, and more than 10,000 also in about 20% of the patient. So they gave 75 to 100 milligram per kg of deferiprone and deferasirox in a dose of 30 to 40 milligram per kg daily. And one can see here over a period of 1 year, there is a fall from 6,800 to 3,545 nanogram per ml in these ferritin levels. Of course, this group did not do the correlation with any MRI of the heart or the liver, and there were no additional adverse effect with the use of two oral drugs combined, just transient GI symptoms, which otherwise also occur, and joint symptoms in some patients, and some patients discontinued the, uh, the periprone because of the joint symptoms. creatinine elevation was seen in about 25%. So the conclusion of this study was that oral combination is safe, efficacious, and a feasible option in patients with suboptimal response to monotherapy. Another study done on 49 patients. This group divided the patient into three groups. One group received monotherapy with deferriprone, the other group monotherapy with deferasirox, and the third group received the drug in combination for over a period of 12 months. And this was shown that in the group which received the combined therapy, the fall in ferritin was maximum. And they also looked at the liver and heart MRI, but the falls were not very significant because the numbers were very small in whom the MRI of the liver and heart could be done. Uh, but they looked at the urinary iron excretion in all these patients, and they observed that combined drug usage produced maximum negative iron balance in the body by maximally increasing the iron excretion in urine from 61 to 343 micromoles per day. And no significant adverse events were noticed in either the monotherapy or the combination group. So again, they said that the combination appears to be an efficacious and safe modality to reduce serum ferritin levels. Another study at our center, 33 patients. Uh, uh, we also use the same dose, 75 to 100 of deferriprone and deferasirox from 20 to 40. After 12 months, the serum ferritin, which was close to 5,000 initially, was decreased in 2 years' time. In those who continued for 2 years, the ferritin decreased to 3,000 nanogram per ml. Those who were having high ferritins to start with, more than 5,000, in them the decline was more rapid. And in those who were having lesser iron overload, the decline was not as that much marked. And in our group also, the therapy was well tolerated. There were some patients with liver enzyme elevation. The hyperbil was observed in some cases, and uh, mild thrombocytopenia occurred in some patients. Otherwise, the therapy was well tolerated. So we see that in Indian patients, we have long-term use of deferriprone, long-term use of deferasirox, and combination therapy with both the chelators because uh, of the affordability. Our country probably needed this type of combination and experience with that. But these studies are from centers where dedicated teams are there for managing thalassemia. But I would just give you some scenario in the real world situation, what is happening. These are the studies which are recently published over the last 5, 7 years. And we can see that the ferritins are pretty high. These are not the studies on iron chelation. They are the studies on other drug uses. But the baseline features in these patients include their ferritins as well, 4,000 here. This is a wide range, but up to 9,700, median ferritin of 3,000, and some with not that high ferritins are there. So in our country, Madam Shobha Tuli pointed out, the uniform management is not there, and there are several factors because of those factors. This results. There are some factors which are dedicating their time. They are counseling the patients properly. Patients are educated, and by their repeated counseling, they adhere to the therapy, and chelation is effective in those patients. But at the other centers, this is not happening. Just a look at the survey of thalassemia management in our country, which Dr. Neeta Radhakrishnan's team recently did. So they surveyed 68 centers, some of them nearly 26 in public sector and 28 in private sector, some charitable, and they are looking after more than 11,000 transfusion dependent thalassemia. So what criteria these people are using is good to see that the serum ferritin of 1,000 nanogram is being used in large number of centers, nearly three-fourths of them, and some centers are deciding the cutoff of 10 red cell transfusions being given, and that is the cutoff taken for starting the iron chelation. Ferritin of 750 or more than 10 transfusions received in some centers, and more than 15 transfusions with a ferritin of 1,000 in one center. And chelator used the first chelator used is 56. That is almost 80% of the centers are using the Ferrocirox as the first chelator. And the decision is based on the affordability, tolerability profile of the chelating drugs. And of course, these drugs are being made available in the country. In the district hospitals have now the thalassemia and hemophilia treatment centers where the government provides the drug free of cost. And the monitoring is being done in these centers. In some centers they are using the cutoff of 2500 sorry, the adding second chelation that is based on two consecutively high serum ferritin levels or an MRI T2 star of fibroscan showing abnormal iron overloading, and the cutoff levels used nearly 50% of them use more than 2000 cutoff, and uh, some use even lower, that is 1500, and some use higher cutoff 3000 nanogram for adding the second iron chelator. So, quite variability is there in the management of thalassemia as far as the chelation aspect is concerned in our country. As I said, the government guidelines were developed and they were put in place in 2016. And each district hospital has a thalassemia and hemophilia treatment center. And availability of iron chelator is ensured is at the center, and the patient do get this drug free of cost. So still the queries remain in the mind of many of the doctors and the patients, uh, when to begin when to begin the iron chelation, which drug to start with, how to monitor whether MRI is necessary, and when to do the first MRI, and when to begin the combination of chelation. So, as Dr. Porter was pointing out, there are different countries, they have different guidelines, and that is what here in this slide also. The TIF says that first line chelator as per the country guidelines should be started. In USA, this first line drug is, by and large, it is deferasirox or DFO depending upon the age of less than 2 years or less than 3 years. In UK and Europe, it is desferoxamine. In Canada, again, desferoxamine, and in Australia it is deferrasrox. So a wide variation is there which drug to be used as the first line. Injectable desferoxamine is is out of question in our country, as I showed that before the deferriprone came up, only 1 to 2% of the thalassemics were receiving, and same way monitoring also is quite variable in different countries. So with this, the think tank of the pediatric hematology oncology chapter, which was looking at the hemoglobinopathies and other disorders, and we requested the Indian Academy of Pediatrics to come out with guidelines, and these guidelines developed over a period of almost 1 to 1.5 years of effort, and they were put in place in 2023. And these guidelines have very clearly stated that chelation should be started once the serum ferritin is over 1000 nanogram per ml, and generally which occurs after 10 to 12 transfusions. So this is the time when first ferritin estimation has to be done. For preventive chelation, deferasirox is the drug of first choice in our country, simply because of the ease of administration, efficacy, safety, compliance, and of course the cost effect. And the addition of a second chelator is recommended in case of persistent, that is over 6 months, persistent evidence of iron overload in the form of serum ferritin over 2000, or MRI evidence of uh, the uh, iron overload in the liver or both, and or symptomatic iron overload or suboptimal response to monotherapy despite dose adjustment and good adherence. So here the use of deferasirox and deferiprone is the easiest and most cost-effective way to reduce the iron burden. That is what the Indian guidelines have stated. DFO is recommended for intensive IV chelation if patient has symptomatic cardiac hemosiderosis, as it is like for the rescue, and if the MRI values are very high. And intravenous DFO infusion is used as emergency therapy also in patients with cardiac arrhythmias or failure. and intensive chelation with DFO is recommended prior to hematopoietic stem cell transplantation. So I think I'm very close to the end of my slides, and monitoring, of course, uh, serial serum ferritin monitoring every 3 months and MRI based. We have stated that the first MRI based assessment should be done at 8 to 10 years, where it can be done without sedation. This is, of course, when the patients are asymptomatic as far as the myocardial iron, the cardiac and liver symptoms are concerned, and chelator toxicity needs to be monitored as recommended in several texts. So to conclude, over the years in India, we have experience which is gathered on long-term use of deferiprone and deferracirol. The combination of two oral chelators has been found to be effective in and safe in Indian studies, and the WHO guidelines have recommended the deferracirol as the first-line chelator, and combination to start if the ferritin is over 2000 nanogram, and DFO is recommended for intensive iron chelation. So I would stop here. Thank you for your kind attention.
Thank you very much.
Over to Dr. Neeta.
Thank you very much, sir, for highlighting the the experience from Indian centers regarding use of chelation and how treatment has been recommended from an Indian perspective. So now we would request both our experts to join for the question answer session. We have few questions in the chat box. Manisha, could you spotlight Professor Porter as well? Yes, thank you. So the first question is from Dr. Naresh Taide. So if a patient shows deposition of iron in the liver by T2 star MRI, but serum ferritin is less than 250 nanogram per ml, and patient is on chelation, what should be done? So as in what he means to say is if ferritin is very low, but still iron overload is evident on a T2 star MRI, how would you go about it? Would you reduce? Would you continue the same dose till MRI evidence has improved?
Okay, I'll have a go at this. I mean, it's much more common the other way around. It's much more common to have a raised ferritin and a normal liver iron. We see this all the time. And this is mainly due to liver damage or liver fibrosis or fatty liver. It's very rare to see a really low serum ferritin when the liver iron is high. I hardly ever see it. So I don't know, maybe Dr. Chandra would like to give his experience.
Well, I think first of all, I would like to recheck the values, whether these values are correct. And if the liver iron is high on the MRI, maybe one can look at the fibroscan. And when, as Dr. Porter said, certainly this does not happen very often. The 250 is a very low ferritin on which you would have a substantial iron overload. This means the drugs which have been prescribed, they have been used, in a very compliant mode, and so that the ferritin has come down. So I would like first to recheck the values.
But we have two patients here with the same
Yeah.
scenario. One
Okay.
girl is a transfusion dependent thalassemic who was never started on chelation. Now she's around 17 years now. And her ferritin levels were always less than 1,000. And so she was never started on chelation. But when we got the MRI, it showed moderate to moderate liver iron deposition. The other is a non-transfusion dependent thalassemic, 300 ferritin, but again, moderate liver iron on an MRI. So in this scenario, we would as start, right? As in
Yeah. Iron chelation would be, see, if it is anti-DT, how old is the child now?
this current patient of Dr. Naresh, I wouldn't know. Dr. Naresh, do you want to unmute and speak? The patients that I am following up, the girl is 17 years and the boy is
Yeah.
around 10 years. The boy has
So in anti-DT, at low ferritin, the liver iron content being high is known.
yes.
And I mean, again, they're also being that low. If you said
Hello.
it is if it is less than 1,000, less than 1,000 means if it is around 700, 800, in that case, one can continue the iron chelation. But if it is less than 250, that would be, one has to take really what to do in such case. I can't suggest that low level of ferritin.
Hello, ma'am.
Yes, Dr.
May
Naresh.
I? So this is the issue. It is actual patient. Patient is now 15 years old, and he is known case of a thalassemia major, receiving transfusion since 3 months of age, and he is taking regular transfusion. Intermittently, he also received the subcutaneous desferoxamine as advised by the hematologist also. But his T2 MRI recently done is show this type of finding, and serum ferritin was low. As sir suggested, we have repeated it twice and thrice. Talk with the pathologist. If this is the case of thalassemia, so kindly give the exact value. But they confirm that the value is definitely low. So I am query ki why then, as there is iron deposition, we have to give. But as serum ferritin is very low, so what drug will be the drug of choice for this patient? Whether we give defiferon because it can cause the iron organ deposit, iron can be removed with that, or any other.
So can I just comment there? So if the patient is being transfused, they are getting iron, and therefore that iron needs to be removed, irrespective of what the ferritin shows. I mean, normally speaking, we use the ferritin as a way of avoiding over-treatment, but I suspect there is something wrong with the way the ferritin result is being obtained here. I'm not saying it's a methodological problem, but it doesn't make sense. They're being transfused, they're not getting chelation, and the liver iron is high. They need treatment. With the end of the story. But I would obviously look carefully for any evidence of toxicity, because this is an unusual case. I've not seen a case like this, so it's very interesting.
So, could it be some other underlying liver disease which is responsible for this type of picture? Dr. Neeta, can we look up from that point of view, maybe some genetic disorder? Nowadays, the whole genome sequencing has become so easily available. We can explore that, and maybe it's not just transfusional iron overload and something else as well.
And in books, they do mention that vitamin C deficiency can falsely
Exactly.
underestimate ferritin values.
Uh,
So maybe that as well.
And the other thing to have a look at would be the transferrin saturation. If patients aren't overloaded, the transferrin saturation should be high. Easy thing to do. If it's low, that would add weight to something strange happening with the iron metabolism. If it's high, as I would expect, I would feel more confident about continuing with the chelation therapy.
Thank you. So the next question is on the role of hepatic fibroscan. Where do you incorporate fibroscan? Do you use it regularly in your practice? I would request both speakers to give their opinion.
Yes, we're using it more and more. And we now have a liver clinic where we get a hepatologist who comes once a month and reviews the difficult cases, but also increasingly the ordinary cases as well. And I think it's helpful. As you know, the fibroscan can be abnormal because of iron, because of fibrosis, or because of fat. It's mainly the fat and the fibrosis we will be concerned about. But it's also very interesting and important if you're considering someone for gene therapy or a bone marrow transplant. You want the liver to be healthy, because you want to avoid VOD, for example, or toxicity from busulfan during the treatment. So our transplanters want to see evidence that there is. Traditionally, they would have done a biopsy and looked for absence of bridging fibrosis on the biopsy. The question now is whether you can use FibroScan instead of that. I would have thought if the FibroScan is normal and the liver iron control historically has been okay for a number of years, that's reassuring. Would also say that if you've had someone who's had, let's say, poorly controlled liver iron, and you're trying to get them worked up for a transplant procedure or gene therapy, and you go in very hard with chelation, and you get the liver iron down to a normal range, the fibrosis will lag behind that. And so the day the ferritin reaches, let's say 1,000, or the liver iron reaches 5, is not the day on which the fibrosis disappears. And so that all needs to be taken into consideration when thinking about risk from procedure.
Thank you. Dr. Chandra? So you're muted. So you're muted, sir.
Yeah, so it's a modality which is not very commonly being used in our country, but it does correlate with the liver iron content, which is assessed by, and as Dr. Porter pointed out, it would also point out regarding the occurrence of fibrosis. So MRI as well as the fibroscan, maybe they may be complementary to each other. It's not just one or the other test. Maybe they can be complementary to each other for assessing the liver condition. But probably, I think more data has to get accumulated before we take such a decision.
So I have a query from my side before we take up the next question. So regarding patients who are being optimized for bone marrow transplant, when we take up a child who has moderate to severe iron overload, say, and very high ferritin, and we put them on IV desferal, how early do you look for response? Do you see responses within 2 to 3 months, or do you want to continue this for like a good 6 months to 1 year before you consider transplant? How early do you look for response following IV desferal?
So I think the consideration is that, as I already said, you can get the liver iron down reasonably quickly. In fact, if the liver iron is very high, it may take 2 years to get the liver iron into a desirable range. That's one thing. And the fibrosis may take even longer. So I think all these need to be taken into consideration. And some transplanters would want evidence that there is no bridging fibrosis on the liver biopsy. And if you're not going to do a biopsy, then the fibroscan can be helpful, but we're still learning about how to use that. So it's difficult to be too dogmatic about numbers.
So usually 6 months to 1 year easily, right? To start seeing
For what?
For improvements in
But will depend upon if it is earlier before the respiral therapy. If it is very high, then it may take longer.
It may take longer, absolutely.
Yeah.
And even, as I say, even when the ferritin comes down to 1,000, you still may have residual fibrosis. And then you have to raise the question, right, do I carry on? Do I wait? It's not like leukemia. If you've got leukemia, you need to get on and doing it. Thalassemia, you have time. And the better you can get the medium-term management of your iron overload prior to doing a intensive intervention, the better.
Thank you. So the next question is from Dr. Gurpreet Singh. He wants to know if a child less than 2 years of age develops hepatotoxicity while on deferoxerox, what would be your drug of choice in that case?
Well, I think Dr. Porter said that we have to weigh the toxicity as well as the benefit. And in such a situation, it would be deferriprone, which would be less toxic. The desferoxamine related bone toxicity under the age of 3 years is well known. So I think one should avoid that. And from deferoxerox, changing to deferriprone would be, something which I would think.
And also the other way around, liver toxicity with deferriprone is actually quite common. Very high ALT. So yes, you can play around with the different chelators and try and say something which doesn't affect the liver enzymes. The kindest drug to the liver is Desferal, if you can take it.
Yeah. So I think the question was also because the child is less than 2 years. So
yeah.
Yeah.
Well, if there's a child's less, I mean, all the details are important. How high is the liver iron? the fraction is probably going to be higher than the liver iron would indicate because of liver problems. And if it's only 2 years, you may want to give a rest period, and see if the enzymes settle, because the risk of cardiac iron is going to be low at that point.
Thank you. So the next question is from Dr. Sejpal. So, so this is an NTDT patient with ferritin of just 280. Liver and heart, there is no iron overload on an MRI, but pancreatic and pituitary iron overload is seen. So the patient is already on deferoxerox 360 milligram 3 times a day, three times a week. So because it's 250 is ferritin only. So what would you advise?
I would advise skepticism, because pituitary iron deposition in the absence of liver or cardiac iron is extremely rare. I would want to know who's measuring these pituitary irons and how validated are they.
So correlate with the pancreatic and pituitary functions as well.
Yes. So the next question is on liver biopsy prior to allotransplants. So are you using it routinely prior to your transplants? And what is the approach? Because that is recommended as per the PESARO classification. How are you risk stratifying?
I missed the key word. With what test was it you were?
Liver biopsy.
Liver biopsy. Yeah. Well, I touched on this briefly. We've had some very vigorous discussions in the UK about this. Some of the transplanters insist on liver biopsy. They've been using liver biopsy for years. They know how to do it. They feel it's safe, and they feel they get important information about, for example, bridging fibrosis that you don't get with fibroscans at the moment. We just don't know. So I understand that argument. On the other hand, patients don't like having biopsies and doctors don't like doing biopsies. So it's a question of getting that balance right. I think there's not enough information at the moment relating fibroscanning to biopsy as a form of risk assessment. We don't really know. I think if the fibroscan, if the control of Iran has been historically good and the fibroscan is normal, then I would be fairly relaxed. But if there has been a history of severe iron overload, or if there's equivocal fibroscan readings, then I think a biopsy may be necessary.
The next question, Dr. Chandra, what is the role of vitamin C in iron chelation? When should it be given and at what dose?
Yeah, Aaron, actually vitamin C has been traditionally recommended to be used in patients who are receiving desferoxamine infusion. And as the text describe that after a few days of therapy, this should be begun, say after half an hour of the subcutaneous infusion has been started in a dose of something like 3 to 4 milligram per kg, but not more than 100 milligram. That is what I understand. I have not used desferoxamine very widely, so too much. So I don't have practical experience, but that is what the TIF guideline also says.
Yes. So the data that iron excretion is increased in desferal treated patients using moderate doses of vitamin C is clear. When vitamin C first became available, or was first shown to be efficacious, some patients went to the shops and bought industrial quantities of vitamin C and went into heart failure. So if you give large doses of vitamin C without chelation, you can liberate iron into the body. You can lead to NTBI formation, and it's dangerous. So if you're going to use vitamin C, you should do it under standard guidelines, as Dr. Chandra mentioned. The information with deferriprone and deferrisarox is not well studied, honestly. There was only one study which was done by Hofbrand very early on with deferriprone. It didn't show a benefit, but I'm not sure how well that was done. And with XJade, again, the drug company wasn't particularly interested in doing a fully randomized controlled study on vitamin C, so we don't really know. What we did find, as I mentioned earlier, is that a lot of our patients who are on XJade and not taking vitamin C end up being vitamin C deficient. We did a special study on that. So I think there is a case for giving low dose vitamin C to patients on deferrisarox, but not enough good data, really.
Thank you. And one final question on deferriprone. When will you absolutely not re-challenge deferriprone? In our country, desferrioxamine availability of the pump is a challenge. So if when we encounter infections and neutropenia, which could be due to the drug per se as well, or it could be infection as well. So when do we decide that we should not re-challenge deferriprone at all?
So I think on this, if there is a severe infection which has occurred in the setting of, say, deferriprone-induced granulocytosis, I would like to avoid Chelation.
And by severe, you mean a neutrophil count less than 100?
Yeah, severe neutropenia, maybe less than 100, and severe sepsis resulting from that. And if the patient has come out of that, I think one should not challenge unless, I mean, as you said, maybe you need to add another drug to deferrisarox, then one has to weigh. But that one has to very, very cautious and begin with the very low dose. But I would avoid re-challenging.
Yeah, I would agree.
Thank you, sir. So with that, I think we come to the end of the question answer session. And I thank both the experts for the talks as well as patiently taking up each question. Now we have Dr. Andrula Eleftherio joining us.
So, yeah. Before that, can I say a word of thanks to the organizing team, and it has been a really enriching experience with Dr. Porter's talk and the question answer session as well. Thank you, Dr. Neeta, and thank you, Madam Shobha Tuli, for inviting me to join this group. Thank you.
Thank you very much, sir. It's a pleasure. I would request Dr. Andrula to say a few words and formally express our thanks.
Thank you very much, Dr. Nida. And let me start first by congratulating all the distinguished speakers and participants that were here. We were very privileged to hear Professor Porter, who is an authority in the area, and not only. So, also, I would just like to mention that now NIDA's center is a TIPS collaborating center. Therefore, we look very much forward to having more and multiple joint projects and activities in the Indian subcontinent. Two things I wanted to say. Thank you, Professor Shankar. You have been a great speaker in letting us know all this information about the studies in India. And I would like to focus on two issues. And in the presence of these medical experts, I would not go into any medical issues, of course, but I would like to comment on two important practical issues. The standardization of the MRI measurements is a huge problem. This is a great challenge, not only in India, but across every country that uses MRI for monitoring heart iron and heart liver iron load. We have observed, even in countries with robust health infrastructures, that the MRI, without a calibration, without a standardization specifically to measure iron load, the results can be very misleading for the treating physician, for the iron chelation, for the monitoring, for the disease progression, and also the FibroScan. We have seen in countries, and just noting some of the results we have had from a few countries of the inconsistency between the FibroScan and the liver iron, and therefore the misleading information that the treating doctor can have. First of all, FibroScan is not standardized in most of the countries to measure the liver iron in these patients. So we have huge inconsistencies between the FibroScan measurements, and we had to go through liver biopsies of a lot of our patients, actually, even in Cyprus, where I live. So we had to refer to the gold standard, which is liver biopsy, to actually underscore and actually prove whether it was a liver disease or whether it was inconsistency of the results of the FibroScan. Therefore, one of the two practical components that we need to look is whether the MRIs that we use are standardized for the T2 star, cardiac, and the liver iron content, but also the FibroScan we use. Otherwise, and particularly in countries that are not dependent on universal health coverage and free services, this is exploiting patients, families, but most of all, they are misleading the treating doctor for how to address the problems in these patients. Therefore, what we are trying to do, and we collaborate in centers such as this of Dr. Nida and others across India and across the world, is to try and see whether we can develop reference MRI centers where they can check the values, whether these are the values corresponding to the real load, particularly in heart and liver. And we have a number of observations, first-hand observations of this inconsistency between the monitoring tools. So we have all this academic information, all this experience, best practices, and we have heard Professor Porter how we can go around iron chelation. We have heard the experiences, the Indian experiences from Professor Chandra. But two practical things, measuring iron load and measuring liver disease, are not in place. So that's the two comments that as Thalassemia International Federation we tried to put forward in India as well as in other countries. And last but not least are the heterogeneity that exists in the guidelines. So we need, each country really needs to have its own guidelines. We are not imposing guidelines, of course. We have TIPS guidelines, and it's very good and very valuable. Each country has national guidelines based on these international recommendations. However, it's good that the country adopts the same guidelines across the country that are adopted by the Central Ministry of Health, because that's the way to actually go ahead and finance these services. Otherwise, if we have different guidelines in the different states across such a large country, it will be very difficult for any government, central or state government, to actually address the costs as well. So with these words, I again congratulate for this series of webinars. I would like to congratulate my friend, Mrs. Chuy, who is sitting next to us, next to me. We are in a board meeting now in Athens. That's why I was late in coming in. And we'll try and work out with all of you across the treating centers and across the treating clinics with our collaborating centers. Now we already have 3, but Dr. Nidas is the first one, and see how we can also upgrade and standardize the monitoring of iron load assessment. So with these words, again, thank you very much. Let me thank Professor Porter, who has been kind and given time to Thalassemia International Federation, without the support of whom we wouldn't have guidelines or any of our educational programs. Thank you, Professor Porter. And I hand on to Mrs. Tooney for a last word.
I think Dr. Nrula has already talked about, what are the problems not only in developing countries, but in the developed world also about T2MRI. I just want to make two comments. One is for our Indian doctors, experts. Dr. Jagdish Chandra is here. And of course, now as Dr. Nrula said that we have the two collaborating centers in India. So this is the time that we together have to think about that. Even for the small testing like serum ferritin, Dr. Neeta, we were talking about that last week, that even if that is also not accurate, and I would like to mention it here, that if a patient is getting it done from one laboratory, if he gets it done next week from the other laboratory, the reports are not matching. And the comment to the first question, which was that the patient's serum ferritin was low, but when T2MRI was done, there was a iron accumulation in the heart. So again, I would say that perhaps this time to look at that, maybe the T2MRI report was not correct. And this is what happened just few weeks back when we got it done in Delhi. So I think there is a need for TIP, and this is my request to the board also. Maybe we have a tomorrow meeting there, and we have been talking about this for many months, almost a year, that how we can improve on to that. So one, my request is to my Indian counterparts that how together collectively we can think and also introduce, in our country, the fibroscan is very important. But I don't think so that many of the patients have access to such kind of highly expensive investigations. For all we know is that in India, it's an out-of-pocket expenditure for most of our patients. And second is request to the tip that it is time now we have to look at that, and maybe Dr. Nrula has talked about the reference centers. We have to see, but especially when it comes to India, maybe one of the center which TIF has to adopt, and we have to make sure that all the reports and the scans are correct and the softwares are in place. So these are the two comments that I wanted to make.
And please do not think that this is an Indian problem. I just want to finish by saying that even in Cyprus, very recently, only just the last week, we have identified only 2 centers out of 74 MRI centers that were actually calibrated. And we have introduced to our health system that these should be the centers that the national health system would reimburse. And they have accepted this because we have seen this inconsistency. So these are the components we need to work on. I'm sorry, but I had to focus on this because all the chelation cost is so high, and we want the benefit of the patients. Therefore, besides the benefit is the cost, and then we cannot assess accurately. Thank you so much for giving me this opportunity. Thank you again.
Thanks again. And a small reminder that International Thalassemia Day is less than 2 weeks away. The theme this year is Together for Thalassemia, Uniting Communities and Prioritizing Patients. So we have a lot of nodal officers who have joined in today. So request you to organize small events at your own center, highlighting this theme for thalassemia.
Thanks, Dr. Rida. You just supported TIP so much. Indeed, it was my commitment to say that. And 8th of May.
Dr. Neeta, don't forget to illuminate your hospital as well. And I'm very disappointed to tell you that our proposal to illuminate India Gate has been not considered because of the Kashmir tragedy. So our PMO has stopped all that, and we have regret has come from the ministry. So, but we must try, whosoever have joined us today, try to illuminate the hospitals and the big centers in wherever you come from with red lights to support thalassemia.
Thank you very much.
Thanks to everyone, and thank you Eco India for joining in this effort. Thanks.
Thank you.
Thank you.
Thank you, everyone. With
Dr.
this,
Chandra, before you go, hello, are you still there? Can you hear me? If you can't, can you hear me?
yes,
Uh,
yes,
and,
Dr.
uh,
John.
the slides from India that Dr. Chandra showed were
Yeah.
interesting to me. And would it be possible to share those so I can have a look
Yeah,
at them?
sure. Yeah, sure. I would love to send. Yeah. Okay. Send
Thanks
it
a lot.
across. Thank you so much. Thank you.
Thank you so much, sir, for joining in. And with this, I'll close the session and request everyone to just submit your feedback for the session. Thank you, everyone.